So welcome to this series called The Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk. So, thumbnail sketch summary of the fluids.
Yeah, so of course, fluids and the whole controversy regarding the volume, composition, and I think perhaps a recognized part of that is the rate of infusion, the bolus issue versus the. I'm reminded by many lectures at Epipalm over the last few years that have characterized those elements. And so, again, we're reminded that composition of fluids, volume of fluid, rate of delivery is important. And I think coming back to the discussion we just had, I think one of the things to me that I keep having to be reminded of is that one of the reasons that this has continued to be a problem is that I don't think we as clinicians necessarily appreciate that there's a cost to pay in terms of harm with giving an intervention like giving a liter of fluid. We just say to ourselves, well, it may not be the right thing to do, but it's rarely the wrong thing to do. And I think we're appreciating that particularly when that happens again and again, it often is the wrong thing to do, and patients develop volume overload. It prolongs their hospital stay. It may prolong their ICU stay. It may lead to complications which are otherwise avoidable. And we're seeing this again and again.
And what I heard you saying is that, when I was a young doctor, you sort of got the impression that if you got the kidney to handle a lot of fluid, somehow it would be happier. Isn't that just kidney work?
Well, I think that is the prevailing wisdom, and like many prevailing wisdoms, it is incorrect. The kidney is in a capsule. It doesn't particularly like to be challenged with volume from simply from a pressure standpoint. But in addition to that, the volume that we give contains a lot of sodium and sodium chloride, and the kidney is the organ that has to handle that has to get rid of that sodium load. We have to remember that there's 9 grams of sodium chloride, 9 grams in a liter of 0.9 normal saline. And so that's quite a lot when you consider what a cardiac diet of 2 grams of sodium is in a day. So I think we have to remember that.
Yeah, I think as was mentioned from I think one of the delegates in one of the later sessions, we really do have to start looking at intravenous fluids as toxins, as well as therapeutic intervention. They really do have significant side effects that we don't always pay attention to, and kidney injury being a prime example.
So we probably didn't emphasise enough in the introduction, John, that you've got a bit of a kidney pedigree, I think. So your title back home is what?
Yeah, so I direct a center for critical care nephrology, and that raised some eyebrows when we opened it a few years ago. So you're not a nephrologist. Why are you wanting to have a center for critical care nephrologist? Well, like perioperative medicine, I think that nephrology is an area that contains certain expertise that is specific to fluids, to acid base, to acute kidney injury. These are things that I've spent my entire career investigating, and I think when we started, it was very unclear that these were big problems, and we now understand that they all are. So the center that I direct focuses on those, and it brings in intensivists, nephrologists, surgeons, anesthesiologists, and many others, actually, who are interested in this.
And the POQI, the Perioperative Quality Initiative that we discussed and in previous podcasts, that's based on ADQI, the ADQI.
The Acute Dialysis Quality Initiative, which was rebranded as the Acute Disease Quality Initiative as we've expanded into some of these other areas, including a meeting we had here in London with you all in the perioperative medicine space, dealing actually with fluids. And it was clear from that and our experience in working with groups involved in sepsis and some of these other areas that the idea of looking at something more than just dialysis and acute kidney injury is something important. And of course, I'm quite gratified to see a sister organization sort of emerge as the POQI and adopt the methodology that we developed some 2 decades ago to try to coalesce both evidence appraisal as well as the importance of expert opinion. And if I may, Monty, I would like to just comment briefly on the importance of expert opinion and expert experience. I think in this age of, certainly in my country, of fake news and alternate facts and a variety of other things that are being sort of in the literature, the importance of expert knowledge has been denigrated, I think, to a certain degree. And in medicine, I think that we run the risk of elevating clinical trial evidence beyond its ability to answer all questions. And so I was taught that it was sort of more of a three-legged stool. It was expert experience and knowledge, it was evidence, and it was the individual patient and their experience that needed to be considered. And I would bring us back to some of that. And I think the POKI process, like the ADKI process, is really all about that.
Mm. So you mentioned the ADKI we had in London, which was very much about fluids, and you showed one of the diagrams from that today, which concentrated on the stages. So it seems that no one doubts that fluid resuscitation is very important when it's needed. So the patient who's hypovolemic, who's dying from lack of volume therapy, it's a lifesaver and it's an organ saver. I think the area of great confusion now is when that patient is established in the critical care unit and they're often many litres positive. Why do we keep watering them on a daily basis and feeding them salt?
Well, it's a good question. I think the answer is complex, but I think part of it has to do with the fact that it's an intervention that doesn't seem to require too much escalation, right? Mm-hmm. So you can you can hang a bag of fluid without, calling anyone. Junior doctor can do that without seeming to need to escalate the therapy of the patient. It doesn't need to move the patient into a higher level of care, for example, if the patient's in a step-down unit, for example. That's, I think, a very important aspect, putting the patient back on vasopressors after they've been weaned, even if it might be the right answer, seems in many people's minds to be much more of an invasive type of thing. It's stepping back. Whereas if I can just solve the problem, at least for my shift, by giving a liter of volume and going away.
And I think that's a very good point. It does temporarily solve that problem. So getting people to not do it is a hard job.
It is. It's a very hard job. And I think one of the things that the era of big data, I'd like to push Dan and others and our own database to look carefully at whether you really do anything with giving this sort of fluid therapy other than just buy some time. Does giving fluid to a patient who's vasodilated do anything other than buy you the shift or maybe a day before you then have to say, okay, now I'm 3 liters positive, 6 liters positive, 9 liters positive, and I'm still in trouble. I've got to go back on this therapy.
John, you showed us some data from the multi-center trial published in the New England Journal of Medicine, I think, which was the early goal-directed therapy trial. And you had 3 groups, didn't you? And one of the 3 groups was the unexpected outlier. Was that right?
Yes, in a number of ways. To remind people who may be listening, this was a study in sepsis, and the use of early goal-directed therapy in that setting involves is a complex algorithm of things like blood products and vasopressors and inotropes and vasodilators. We had a third group, which was in order to deal with the fact that if you're just randomizing people to usual care versus a complex algorithm, you have a Hawthorne effect. Mm-hmm. And we wanted to be sure that the team and the protocol itself wasn't somehow driving any potential outcome, any potential benefit. So we had a structured resuscitation protocol that was very much what we, sitting around talking about what intensivists do at the bedside, sort of do, but in a structured protocolized way. And because it was a structured protocol, it tended to give more volume than either of the other 2 arms. And what you're referring to is the fact that actually, if you look at the data carefully, you see that there is no benefit in terms of mortality, but the morbidity signal actually goes the wrong way. The more fluid that you give seems to be associated with, and in this case, causally, with more morbidity, including renal dysfunction.
That was this third group. So it wasn't the early goal-directed group or the control group. It was the third.
It was this what we call the protocolized standard therapy group.
And they ended up receiving more renal replacement therapy.
They did.
And one of the things you didn't allude to today, which I've become very interested in, that group had a higher CVP.
It did indeed.
Yeah, I don't know if the other guests here are aware of this. That seems to be a recurring theme if you look closely at some of the literature. If you look at some of the fluid trials, I mean, doesn't the kidney like a high CVP?
It doesn't appreciate a low CVP or a high CVP. It appreciates a more normal CVP, like many of our other organs. And the reason for that is that there's back pressure on the kidney. If the right heart fails or simply becomes volume overloaded, the perfusion pressure in the kidney is going to be diminished. And particularly when we speak about things like mean arterial pressure of 65, 65 against a CVP of 4 is different than a CVP 65 against a CVP of 24.
So that's worth people looking very closely at, because it's a little recurring theme in there.
It is indeed.
Chest trial, which addressed a different questions, colloid crystalloid, higher CVP. More renal replacement therapy. It's an association, not making too much of it. You're an output because Tim.
I was just going to be clear. We didn't actually name the trial, so just for the listeners, this is the process.
This is the process trial. That's
that
right.
You're speaking about.
Yeah. There are other trials available. Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.